So wish you all a very good evening. I'm not sure whether I will be knowing someone of you there. So uh, anatomy, as you all know, it's not easy to have a crash course within 2 or 3 sessions. So what I'm planning to do is most of the gross topics you might be knowing, or you might have come across the same topic in surgery, gynec, etc. But some of the core topics which you need to know, which are exclusive for the anatomy, that I will be dealing here. So today what I'm planning to do is we'll be just rushing through some of the important topics in general embryology. And as far as NEET or any entrance exams are concerned, most of the questions in embryology comes from the general embryology part. And NEET is actually having questions based on diagrams and images. So I'll be adding some of the diagrams and images which are their favorite side, so that you will be able to pick the correct answer or name or label it. So if you have any, it won't be possible to have an interactive session due to the time constraints. So if you have any doubt, you are free to message me. I will just give my number in the chat box. I will get back to you. So we will just have a rush through of the topic general embryology under some of the important headings. I'm having almost 200 slides, so please be with me. We will be finishing it in 1.5 hours mostly. So with this intro, I'm going to start this today's session. Can I have a yes from some of you in the chat box? 3 or 4? Okay, thank you so much. So let's start. So general embryology, I'm planning to start with the gametogenesis and reproductive cycle. All these topics you know very well. So I'll be just having a quick recap of these topics. Primordial germ cells. These are the germ cells which give rise to gametes, and the main purpose is to restore the diploid number. So primordial germ cells arise from, it is from the yolk sac you have the primordial germ cells. Now we will have a quick review about the spermatogenesis. Spermatogenesis, we know it starts with type A dark spermatogonia, which gives rise to type A pale. Then you have type B spermatogonia, and from where you get the primary spermatocyte. So we know the first one, it is diploid in number, isn't it? So spermatogonia, they are diploid in number, and it will be giving rise to primary spermatocyte again by just mitotic division. More number of cells will be formed by mitotic division. And after that, you have the secondary spermatocyte. There you can see that the number is actually haploid. There is reduction of chromosome number. Then you have the spermatid, and finally you have the sperm or spermatozoa. So this is actually the spermatogenetic cycle. So spermatogonia, this is the section of the testis, and you can see the Sertoli cell, and on the sides of the Sertoli cell you have the cells arranged starting from spermatogonia. So spermatogonia, you have the DNA replicated in the form of 2N. It will be becoming the primary spermatocyte. Then it will be transformed into secondary spermatocyte. So secondary spermatocyte will be having the haploid set of chromosome numbers, and after that it will be transformed into spermatid, which is actually immature haploid gamete, and finally into spermatozoa. They are the matured ones. Now spermatids to spermatozoa. Spermiogenesis actually is the process by which the spermatids actually mature to become spermatozoa. Now some of the changes which happen to the cell to become the sperm, you need to know. These are some of the favorite MCQ part. So formation of head cap or acrosome cap. This is the head cap or acrosome cap. It is from the Golgi vesicles of the cell. Then what happens to the nucleus? Nucleus actually condenses and gets covered by the acrosomal cap and projects out as the head of the sperm. So nucleus is actually forming the head. The acrosome cap is actually the Golgi vesicle. Now, what about the remaining structures? You can see the centrosome here. It is actually dividing into 2 centrioles. The proximal centriole forms the axial filament in the neck, and the distal centriole actually forms the annulus or ring at the distal end of the middle piece. So this is what is happening to the centrosome. Then you can see that the axial filament which extends from the neck to the annulus is actually covered by the mitochondrial sheath to form the middle piece. And the remaining axial filament elongates to form the main and end piece of the tail. So this is very important. You will get n number of MCQs from this part. And what happens to the residual bodies of the cell? It is actually phagocytosed by the Sertoli cells which are lying nearby to it. So this is just again a quick review. You have the acrosomal cap from the Golgi apparatus, head from the nucleus. Then you have the centrosome, which is divided into two centrioles, proximal and distal. Then you have the axial filament, which is actually forming the principal and end piece of the tail. So the process of becoming spermatozoa from the spermatogonium, the total number of days, it is 64 to 74 days. And the spermiogenesis exclusively require 24 days. And where is the site of attaining the motility for the spermatozoa? It happens in the epididymis. So spermiogenesis is actually the transfer of the spermatid to spermatozoa. Which of the following is haploid? Type B spermatogonia, primary spermatocyte, secondary spermatocyte, type A. So we know the spermatogonia, every spermatogonia will be having diploid number. Primary spermatocyte is also diploid in number. The secondary spermatocyte is actually haploid. Golgi vesicle forms which part of spermatozoa? We know it is the acrosome cap. Tail of the sperm is formed by, we already mentioned it as the axial filament, which is actually forming the principal and end piece of the tail. Then spermatozoa attains full motility at the epididymis. Now coming to the oogenesis. Oogenesis, when we compare with the spermatogenesis, we know spermatogenesis actually begin during puberty, whereas oogenesis starts before birth. So that is the main difference. So when we talk about oogenesis, we have to mention about the changes happening for the oocyte as well as the changes happening for the follicle. These are the two headings under which we explain the oogenesis. So like the spermatogonium, we have the oogonium, which will be converted to primary oocyte, that is the mitotic division, and this division actually begins before birth. And when a baby is born, when we check the ovary of the newborn baby, it will be having primary oocytes arrested in prophase of the first meiotic division. Okay, so that is the first and foremost thing which you should be knowing. Primary oocyte arrested in prophase 1. And till puberty, this will be arrested. And what will happen further? With every ovarian cycle, say 10 to 15 number of these oocytes will begin its maturation process and one of it will be ovulated. So this is the main difference between spermatogenesis and oogenesis. So at birth, every female child will be having primary oocytes arrested in prophase 1. Then what happens? It will be undergoing meiosis 1 to form the secondary oocyte. And then what happens? The secondary oocyte will be actually arrested in the metaphase. The second meiotic division will be arrested in metaphase, and it is the secondary oocyte with arrested metaphase which is getting ovulated. And this will be completed only if it is fertilized by the sperm, or otherwise what will happen? It will be just menstruated. The oocyte will be still in the metaphase of the second meiotic division. So that is very important. First arrested in prophase, then during ovulation, it is arrested in the metaphase. These 2 points are to be noted. And you can see that the change is happening to the follicle. It starts with the primordial follicle, then the primary follicle, then the mature follicle, then finally the Graafian follicle. So 10 to 15 follicles will start its maturation process, and only one will be actually being maturing as the Graafian follicle, and that will be actually liberated. And finally, the remaining part of the Graafian follicle will become corpus luteum. Now, approximately 40,000 oocytes are present at puberty, and less than 500 will be ovulated during the reproductive cycle. So, at birth, the oocytes are suspended at which phase? We know at birth it is prophase. So, prophase, we have two options, meiosis 1 and meiosis 2. So, it is meiosis 1. The prophase of meiosis 1 may last till, that is the next question. So, it is actually not till puberty, because at puberty all the oocytes won't mature. Only a few selected will be maturing with every ovarian cycle. So some of the oocytes may last till the lady attains menopause. So that is the reason why it is mentioned it as 40 years or more. And that is the reason why we get Down syndrome and all due to non-distinction, due to the aging of the oocytes. Before ovulation, the Graafian follicle contains. So Graafian follicle just before ovulation will be arrested at the metaphase. So which metaphase? Secondary oocyte at the metaphase of the second meiotic division. These 2 points are to be noted every time asked. Now, something about the ovarian tissue freezing. It is actually removing and freezing the ovarian tissue when a woman is planning to undergo radiation or chemotherapy. The ovaries will be destroyed. So, in order to prevent that, if she is in the reproductive age group, we will just remove it, and after the therapy, we will just reimplant it. That process is known as ovarian tissue freezing. Now, can you identify this tumor? So this tumor is oropharyngeal teratoma. So the tumor arises from, we have two options, primordial germ cells, epiblast, and we have both or none. So teratomas actually should be arising from the cells which are capable of giving rise to all the three germ layer derivatives. That is the word meaning of teratoma. So here we have primordial germ cells and epiblast. Epiblast is the layer from which all the three germ layers are finally conceived. So that is very important. And primordial germ cells, they are also capable of giving rise to all the three germ layers. So the answer is both. Now, yes, some of you are trying to answer. Sorry, I'm not able to see the chat box simultaneously. So coming to the ovarian cycle, the cyclical changes in the ovary. It persists throughout the reproductive period except during pregnancy, and it terminates at menopause. So some of the changes which happen, let's discuss. You have two hormones, follicle stimulating hormone and luteinizing hormone. They are actually the main hormones running this cycle. So what is the role of FSH? It induces the growth of ovarian follicles, which in turn will secrete estrogen. Now, effects of estrogen. Some of the favorite short MCQs are, what are the effects of estrogen? All these are the effects of estrogen, except something like that. So the effects of estrogen include forming secondary sex characters, proliferation of endometrium just before ovulation, then feedback inhibition of FSH. It stimulates the LH secretion, and this LH actually induces ovulation and formation of corpus luteum. So these are the changes which happen with the help of estrogen. Now, what are the effects of progesterone? So when we say the ovarian cycle, the first half is estrogen controlled and the next half is actually progesterone controlled. So progesterone, the effects of progesterone means it prepares the uterus for receiving fertilized ovum. Then it prevents the expulsion of ovum by lessening the contraction of the uterine muscles, and it also inhibits FSH and thereby maturation of follicle during corpus luteum formation. These are the main effects of the progesterone. Now, this is the cycle which you should be remembering. First, we have the FSH, which will stimulate the follicles, and they will secrete the estrogen. And as an effect of estrogen, there will be LH surge. Then there will be ovulation. Then there will be formation of corpus luteum, which will in turn secrete progesterone, and this will have an inhibitory effect on FSH. So this is the cycle which you should be knowing. Now coming to the two phases of ovarian cycle, you have the follicular phase and luteal phase. Follicular phase means the follicles are developed and release one mature oocyte, and luteal phase is the formation of corpus luteum. So follicular phase comprises of the primary oocyte, then you have the follicular cells proliferation, then you have the zona pellucida formation, then you have the theca formation. So these are the main headings under which you will discuss about the changes inside the follicle. So this is just an overview. You can see the primordial follicles which are converted into primary follicle. Then you have the secondary follicle. Then you have the Graafian follicle, which is actually liberating the oocyte. And after that, it will become corpus luteum. And the final end product of corpus luteum is corpus albicans. So these are the changes which happen to the follicle. So it is said that 15 to 20 primary follicles are stimulated with every ovarian cycle, and the rest of the only one will be becoming the mature Graafian follicle, and rest of the follicles, say if 15 are there, one will be becoming the Graafian follicle, and the rest of the 14 will be becoming corpus heteroticum. And it will be converted into secondary follicle. Then the secondary follicle will have the theca. The theca layers will be actually organized into an outer theca externa and an inner theca interna. And these are the two important components of the Graafian follicle. And this theca interna is actually producing the follicular fluid and some of the estrogen. This is also very important. Out of theca externa and interna, which one produces? That is theca interna. And the meiosis 1 is actually completed and the secondary oocyte is formed within the maturation of the Graafian follicle. And you can see the position of the polar body. So first polar body actually lies between the zona pellucida and the cell membrane of the oocyte. That is, the space is actually known as perivitelline space. So if you see the perivitelline space, you can say that the first meiotic division is complete and the first polar body is released. Now meiosis 2 is initiated. We mentioned it as it is at the time of ovulation, it is arrested in the metaphase. And during ovulation, there will be increased prostaglandin level due to the LH surge. And this will cause the muscular contractions in the ovarian wall. And that is how the oocyte is liberated into the peritoneal cavity. So prostaglandin also plays an important role. Then you have the secondary oocyte, which is expelled during ovulation, and the importance of zona pellucida and corona radiata. These are the two important structures which will help in fertilization and implantation. The roles of it, we will be dealing it later. So the secondary oocyte will be carrying some of the cells, the granulosa cells in the form of corona radiata, and you have the zona pellucida. This is the form in which you liberate the secondary oocyte. You might have heard about this term Mittelschmerz. It is nothing but pain experienced during ovulation. This term means middle pain and it occurs near the middle of the menstrual cycle. And anovulation means absence of ovulation. Now something about corpus luteum. Corpus luteum is actually formed under the influence of LH. Luteinizing hormone forms luteum. So granulosa cells and theca interna cells, which are the cells contributing the formation of lutein cells. So they are the granulosa cells and theca interna cells. And what do they secrete? They secrete estrogen and progesterone, and their role is to prepare the uterine endometrium for the implantation of the embryo. So that is the role for the luteal cells. And after that, once their role is over, it will become fibrotic scar that is known as corpus albicans. So the progesterone production actually decrease when the progesterone production decreases, the results menstrual bleeding. We know when we discuss about corpus luteum, there are two entities. One is corpus luteum of menstruation and the other one is corpus luteum of pregnancy. So corpus luteum of menstruation actually it will be present just for 1 or 2 weeks, but corpus luteum of pregnancy, it will be there till at the end of the first 20 weeks. That means till the placenta takes over, this corpus luteum will be providing progesterone for maintaining the pregnancy. So it is said that if you remove corpus luteum from the ovary of a pregnant lady before 4 months, then it is enough to cause an abortion. That is very, very important. Then degeneration is actually prevented. The degeneration of the corpus luteum is actually prevented by HCG secreted by the syncytial trophoblast. When we discuss about the blastocyst, the trophoblast will be differentiated into two layers, the outside trophoblast. So the syncytial trophoblast is actually secreting HCG, which prevents the degradation of the corpus luteum. Now, we know the placenta produces estrogen and progesterone necessary for the maintenance of pregnancy. Till the placenta takes over, it is the corpus luteum which does this function, and that is the reason why if we remove it before 4th month, it leads to abortion. Ovarian cycles actually terminate at the menopause, roughly 48 to 55 years. So this is just a cycle flow chart describing the role of the hormones. Hypothalamus, it starts with hypothalamus, which secretes gonadotropin releasing hormones, and they act on pituitary, the adenohypophysis, and they secrete two important hormones, FSH and LH. Both act on ovary. FSH stimulate the growth of follicles, whereas LH results in the ovulation process. Follicles secrete estrogen and they help in the proliferative phase of the uterine endometrium. And the progesterone secreted by corpus luteum results in the secretory phase of the uterine endometrium. These can be asked as an MCQ or all except, just like that. So please have a thorough review of this. Now, coming to the phases of the menstrual cycle, you have the initial 4 days known as the menstrual phase, followed by the proliferative phase, then you have the secretory phase, and then you have the premenstrual phase. So altogether in a normal cycle you have 28 days. So this is just a comparison. You can see the follicular phase and luteal phase of the ovarian cycle, and you have the changes happening in the endometrium. You can see the menstrual phase, proliferative phase, secretory phase, and the premenstrual phase. So you can see that these two are actually coinciding. And you can see two peaks for these hormonal levels. One peak is for the estrogen in the initial phase, and the second peak is for the progesterone in the second phase. And you can see the FSH and LH surge results in ovulation. So if you have a pictorial representation of this in your memory, it will be easy for you to solve many of the questions. Now, menstrual irregularities, amenorrhea, you know, it's absence of menstruation. Primary amenorrhea means there is no menstruation even after 16 years. Secondary means stoppage of menstruation, which was normal before. So it can be as a part of pregnancy. Hypomenorrhea means scanty blood flow. Oligo means menstruation occurring at intervals more than 35 days. Menorrhagia is increased bleeding during menstruation, whereas metrorrhagia, metro means in between, bleeding in between the menstrual cycles. So all are effects of estrogen. Secondary sex characters, proliferation of endometrium before ovulation, feedback inhibition of FSH, prevents expulsion of ovum. That is actually preventing expulsion of ovum, maintenance of pregnancy is the role of progesterone. Which phase belongs to ovarian cycle? So secretory, premenstrual, menstrual, luteal. It is the luteal phase, the follicular and luteal phase, which belong to ovarian cycle. Theca interna, it secretes estrogen. The other hormones are not secreted by the interna. It is mainly secreting estrogen. First polar body lies in perivitelline space. So that is actually between the vitelline membrane and the zona pellucida. So that plane you should be knowing. Where will you get the first polar body? It is between the vitelline membrane and the zona pellucida. Now we are moving on to the fertilization. Fertilization, as you know, there are mainly two types. One is in vivo and the other one is in vitro. In vivo fertilization, you know, that is a normal type of fertilization which happens in the body. In vitro means outside. So in vivo, the commonest site for fertilization is actually the ampulla of the uterine tube. And the process of fertilization happens in three stages. First, the gametes should be transported to the ampulla. You have to get the oocyte from the ovary, and you have the sperm which is implanted in the uterine cavity. They should be transported to the uterine tube. Then the fusion of gametes, and then the results of fertilization. Now, another favorite MCQ is from this area. Which are the hurdles of sperm entry? You can see the corona radiata, you can see the zona pellucida, you can see the perivitelline space, and finally you have the vitelline membrane of the oocyte. So these are the hurdles which a sperm has to these are the hurdles through which the sperm has to pierce in order to reach the vitelline membrane of the cell, oocyte. So before fertilization, in order to enter into an oocyte, all the sperms are not capable of entering into the oocyte, right? So before fertilization, some changes has to occur for the spermatozoa so that it can pierce the vitelline membrane of the oocyte. So what are the changes occurring for the sperm? There are mainly two changes. One is capacitation and the other one is acrosome reaction. So capacitation happens in the uterine tube, roughly 7 hours it will take, and the glycoprotein coat of the plasma membrane overlying the acrosome region of the spermatozoa, that the coat is actually removed. That is the first step. Then you have the acrosome reaction. Acrosome reaction means the acrosome cap contains enzymes like hyaluronic acid and phosphatase, hyaluronidase and acid phosphatase. So these are the two enzymes which are resulting in the acrosome reaction. Now you can see which are the agents, the chemicals acting at each level. This is also asked frequently. So at corona radiata, you have the hyaluronidase. Zona pellucida, you have the acrosin. And vitelline membrane, you have the integrin peptides. So this you have to keep in mind, which are the chemicals acting at the entry levels. Corona radiata, hyaluronidase, zona pellucida, acrosin, and vitelline membrane, integrin peptides. Now the results of fertilization. So by the when an oocyte is fertilized by a sperm, Then you can say that the female gamete completes second meiotic division. That is the point where the second meiotic division is completed, and after the second meiotic division only you will get the second polar body released into the perivitelline space. So if you see only one polar body, it means first meiotic division is completed. If you can see two polar bodies in the perivitelline space, it means that the second meiotic division is also completed. And as a result, you can see there are two pronucleus formed. One is female pronucleus and the other one is male pronucleus. And this process actually helps in restoration of the diploid number for the zygote. And what are the other changes happening? You know, chromosomes, it is actually, they are actually shared from both the parents. You have an equal share, but cytoplasm of the zygote is actually or exclusively from the mother's side. And the sex of the offspring is actually determined by the father. And after that, the cleavage begins. You can see the female pronucleus, the two polar bodies, and you can see the cleavage has begun, and you can see the two cell stage. What is happening when you talk about fertilization in vitro? When the fertilization happens outside the uterus, what are the steps? First, you need the oocytes and you need the spermatocytes. So from how will you get the oocytes? That is done by hormonal stimulation. And as a result, you can actually retrieve the oocytes with the help of laparoscope. And you can, with the help of ejaculation, you can get the sperms, and they are both fertilized outside the uterus. And the embryos will start cleaving and they are cultured, and up to 3 embryos are usually implanted into the uterine cavity, because we are not sure whether all the 3 will be maturing or not. So roughly 3 embryos are usually implanted, and we hope one to become a mature fetus. And rest of the embryos are kept frozen for future use. Now, something about gift, gamete intrafallopian transfer. This is actually done when the cervical mucus is actually hostile. So when the cervical mucus is hostile, we need to take these gametes across this mucus and directly into the uterine tube, so that the gametes will land safely in the uterine tube. And this process is known as gamete intrafallopian transfer. Now, other techniques are single embryo transfer, intracytoplasmic sperm injection, or known as ICSI. So all these are different methods of in vitro fertilization. Most common is site of fertilization. It is ampulla. Hurdles of sperm entry are all except we mentioned about the corona radiata, zona pellucida, vitelline membrane. It is not stratum compactum, because stratum compactum is actually a part of uterine endometrium. Now, removal of the glycoprotein coat overlying the acrosomal region of the spermatozoa is called the first reaction, that is the capacitation. Now, the chemicals, how will you match it? You have corona radiata, zona pellucida, and vitelline membrane. So, corona radiata, the chemical is hyaluronidase. Zona pellucida, you have the acrosin, and vitelline membrane, you have the integrin peptides. Now, following are the results of fertilization, except. So, what are the changes? You know, as a result of fertilization, the second meiotic division is completed. It is not the first polar body in perivitelline space. You will see 2 polar bodies in the perivitelline space. Then there will be restoration of the diploid number, and the cleavage division will also begin. Which of the following is an example of in vitro fertilization? All the above. We have discussed about gift, gamete intrafallopian transfer. We mentioned about single embryo transfer. We mentioned about intracytoplasmic sperm injection. All these are different methods used in vitro fertilization. Now we are moving on to the different stages, like what's happening in the first stage, second stage, third stage after fertilization. Okay, so there are mainly 2 stages when we think about the growth of the zygote inside the womb. The first one is embryonic period, and the other one is fetal period. So embryonic period is actually mentioned from the point of fertilization till 8 weeks. And only when the embryo finishes 8 weeks, you can call it as fetus. So you name it as fetus only after 8 weeks. So, or we can roughly say that after the second month or from 3rd month onwards, you can call it as fetus till the termination of pregnancy. And the embryonic period is actually further divided into 2. That is, out of the 8 weeks, the first 3 weeks are known as germinal period because you will get the 3 germ layers developed in the first 3 weeks. So it is from the fertilization till 3 weeks, and after third week, that is from 4 to 8 weeks, you call it as embryonic period proper. And what are the changes happening during the first week? We have already mentioned about the cleavage division. So after fertilization, you have the cleavage division, you have the formation of morula, blastocyst till the point of implantation. So these are the changes which happen in the first week of development. So you can see 2-cell stage, 4-cell stage, morula. So when will you call it as morula? 8 to 16 cell stage, that is known as morula. And the cells are actually grouped as outer cell mass and inner cell mass. So outer cell mass, what are the type of cell junctions you get there? The outer cell mass, the cells are arranged with the help of tight junctions, and they give rise to trophoblast and chorion. What about the inner cell mass? Inner cell mass, you have gap junctions, and it is the inner cell mass which gives rise to the embryo proper. So this transformation you should be knowing. And morula is actually covered by zona pellucida. Zona pellucida is still there. Now coming to the blastocyst, it is from 32 to 64 cell stage. There are mainly the blastocyst. When it becomes blastocyst, the trophoblast will be modified as two. One is polar trophoblast and the other one is mural trophoblast. Where will you call it as polar trophoblast? The trophoblast which is actually covering the embryonic pole. So this is the future embryo, the inner cell mass. The trophoblast line covering the embryonic pole is known as the polar trophoblast, whereas the remaining trophoblast, you call it as mural trophoblast. So sometimes an image can be shown like this and a pointer can be pointed like, so what is this trophoblast? Mention the type, etc. So this is polar and the remaining one is mural trophoblast. Coming to implantation. So there are mainly 3 zones of decidua from within outwards. When we talk about the endometrial lining of the uterus, there are mainly 3 layers: stratum compactum, stratum spongiosum, and stratum basal. From outer aspect to when you go deep, it is outermost one is stratum compactum, then you have the spongiosum, then it is basal. When will you call this as decidua? Once the blastocyst is implanted within the uterine endometrium, after the implantation, then you no longer call it as stratum compactum, spongiosum, and basal. You will be calling it as decidua basalis, capsularis, and parietalis. So the same thing, the stratum is called decidua after implantation. So when will the implantation occur, or which structure prevents implantation? This zona pellucida, which is actually covering the blastocyst, is just like a sticker. If you peel it off, the blastocyst will go and stick onto the uterine endometrium or anywhere. So it is the zona pellucida which actually decides where the blastocyst should stick onto. So it happens usually by the end of 5th day after fertilization. So after the 5th day, the zona pellucida disappears and now the blastocyst is ready to go on and stick onto the uterine endometrium and get implanted. So the implantation happens through the polar trophoblast, and this polar trophoblast will be the first part which sticks onto the endometrial layer, and it will erode the 2 layers, the stratum compactum and stratum spongiosum of the uterine endometrium. Now, this implantation is also facilitated by the proteolytic action of trypsin, which is secreted by the trophoblast. And the embedding or implantation occurs by the end of 5th or the beginning of 6th day or 7th day after fertilization. The implantation begins and it is not completed by 6th or 7th. It will be completed only, say, roughly 12th or 13th day after fertilization. And the implantation site, it is usually said to be normal if it happens at the junction of the fundus and posterior wall of body of uterus. And nowadays it is said if it is implanting in the upper part of the uterine cavity, it is normal. Whether it is anterior or posterior, we consider it as normal implantation. Only if it is implanted in the lower part, you call it as abnormal implantation. So these are the changes you know, you have the fertilization happening here in the ampulla, then you have the 2-cell stage, 4-cell stage, the morula, then you have the blastocyst with the blastocele, the cavity. And after the end of 5 days, on the 6th day, the implantation begins. And it is the polar trophoblast which is sticking first. And finally, it will be completely embedded in the stratum compactum and stratum spongiosum of the endometrium of the uterus. When will you call it as extrauterine pregnancy? If this implantation happens anywhere other than the upper part, you call it as ectopic pregnancy. So if it is extrauterine, means it should be outside the uterus. So it can be in the ovary, it can be in the abdominal cavity, especially the pouch of Douglas and great omentum, or it can be in the uterine tube. And tubal pregnancy is said to be the commonest compared to the other sites. And when will you call it as intrauterine but still abnormal implantation? That is when the implantation happens in the lower part of the uterine cavity. And that is particularly called as placenta previa. That's a particular term. It is intrauterine abnormal implantation. So placenta previa, you know, there are mainly 4 stages. There's a stage 1, stage 2, stage 3, stage 4. Stage 1 means it is just the lower segment. Stage 2 means it encroaches the os. Stage 3 means it covers the os, but on dilatation, it will be moving away. And stage 4 means it completely covers even on dilatation. Now, ectopic pregnancy, these are the commonest site. You can get it in mesentery, uterine tube, you can get in the ovary, you can get it in the fimbrial end. And if it is intrauterine, you can get it in the lower segment as well. Identify the site of ectopic pregnancy. I haven't changed the labels. It is easy then. You can see the fimbrial end and it is written as ruptured oviduct. So the answer is, identify the site means it is the fallopian tube. Now, coming to something about stem cells. Embryonic stem cells and adult stem cells. These are again some of the questions which are asked recently. Embryonic stem cells are actually derived from the inner cell mass, the cell mass which are giving the cells which are giving rise to the embryo. So the peculiarity of these stem cells are they are pluripotent. Pluripotent, the term means it can give rise to any type of tissue. And how are these cells derived? They are obtained from the embryos after in vitro fertilization. So there are many ethical issues for these embryonic stem cells. And 2 methods for which they are used are therapeutic cloning and reproductive cloning. So in therapeutic cloning, what we do is we actually take the needed cell from the adult and we get the nuclei from that cell and we actually implant it into the oocytes which doesn't have any nucleus, and it will be undergoing transformation to form a blastocyst. So there is no fertilization. It is just a method of cloning, and there are no sharing of chromosomes. It is just the needed cell nucleus which we are taking and just cloning. That is therapeutic cloning. Reproductive cloning means we take the cells from the embryo after in vitro fertilization. Some of the disease treated with this are diabetes, Parkinson's disease, anemia, spinal cord injuries. Now, what about adult stem cell? Adult stem cell means these are the cells which are multipotent. Difference between pluripotent and multipotent. Multipotent means the same type of cell you can get it in any number. Whereas pluripotent means the cells are capable of giving rise to any germ layers. So the adult stem cells are not pluripotent but multipotent. Increase in the number of same cell type. All are correct about implantation of blastocyst. It implants in the endometrium, attaches to the endometrium at its embryonic pole, implants in the posterior wall. Implantation occurs on 4th day. It is not the 4th day, it is by the end of 5th day. With light microscope, zona pellucida appears surrounding all primary oocyte, zygote, morula, implanted blastocyst. We know only once the zona pellucida disappears, the blastocyst can implant. So implanted blastocyst won't be having the zona pellucida. Now, this is just a quick recap about the normal gestational period. It is set as 40 weeks or 280 days after the last menstrual period. How we calculate is from the last menstrual period, we add 9 months plus or minus 7 days. If you want to be more specific about the growing fetus, the age of the growing fetus, it is actually 266 days or 38, 2 weeks less after uh, the LMP. The reason is, we know if we have the first day of last menstrual period, only after 2 weeks we have the ovulation, and then only the fertilization will be happening. That is the reason why we have 2 weeks less when we talk about the ideal age of the fetus. So zygote till newborn, the number of days, it is actually 266 days or 38 weeks. If you are starting from the point of first day of last menstrual period, it is 280 days or 40 weeks. Now, we have mentioned about the embryonic period and fetal period. Embryonic period, first 8 weeks, out of which the first 3 weeks you have the germinal period, the 3 germ layers, and the remaining period you call it as embryonic period proper. So embryonic period is from the point of fertilization till 8 weeks, you call it as embryo. After 8th week, we call it as fetus. So fetal period starts from 3rd month to birth. So these are very favorite questions. You will be confused if you are not thorough with this terminology. Okay, so fetal period. When will you call an embryo as fetus? Only from the 3rd month till birth. 8 to 16 cell stages, morula. All are examples of extrauterine pregnancy: ovarian, tubal, placenta previa in pouch of Douglas. So all are actually options for ectopic pregnancy. But in ectopic pregnancy, which are extrauterine and which are intrauterine? So placenta previa is actually ectopic but intrauterine. All the rest are ectopic but extrauterine. Now, we are moving on to the second week. Second week means what are the changes happening to the embryonic cells and the extraembryonic cells. So some of the extraembryonic structures formed in the second week. These all you can get as options. So you should be knowing what are the extraembryonic structures. The amniotic cavity here, the yolk sac, the chorionic sac between these. Then you have the amnion. Then you have the chorion, the primary villus, the connecting stalk. Everything are outside the embryo. So you call it as extraembryonic structures. So what are the changes happening in the germ disk or the cells forming the embryo? We know there are 2 layers formed. So it is the second week, it is rule of 2. If you want to know the details, you can watch my channel. I've dealt the topic in detail. Due to time constraints, we'll be just rushing through. So you have the epiblast and you have the hypoblast. Epiblast you call it as primary ectoderm, and hypoblast you call it as primary endoderm. And above you have the amniotic cavity filled with lycramne, and you have the blastocele, the blastocystic cavity lined by the Husser's membrane. So Husser's membrane lines what? The inner aspect of the blastocystic cavity. This can be asked. Now, the exocoelomic cavity or the primitive yolk sac. This is the primitive yolk sac. Now, you also have the formation of the extraembryonic mesoderm. That is the primary mesoderm. So, the mesoderm which is formed outside the embryo and which is the first formed mesoderm, it is actually the extraembryonic mesoderm. And the cavity formed within the extraembryonic mesoderm is called as chorionic cavity. So, here you can see this purple colored thing is the extraembryonic mesoderm, and the cavity formed is the chorionic cavity. And the connecting stalk is actually getting transformed as the umbilical cord. You just imagine this part getting obliterated. It will just fall off, right? So this is the connecting stalk, which is later on forming the umbilical cord. Now this extraembryonic mesoderm is divided into 2. The parietal layer, otherwise known as somatopleuric, and the visceral layer, which is otherwise known as splanchnopluric. So splanchnopluric is the mesoderm which is lying or covering the yolk sac portion, whereas the part which is covering the amniotic part and also lining the trophoblast. These are the 2 different layers of trophoblast. The cells which you are seeing are the cytotrophoblast, and the blue colored thing is the syncytial trophoblast. Outer syncytial, inner cyto. And then you have the purple colored layer, that is the somatopleuric extraembryonic mesoderm. So sometimes a pointer can be shown like this. So what is this layer? So the purple colored thing lining the trophoblast as well as covering the amniotic cavity, they are the somatopleuric layer. And the one which is covering the yolk sac portion, it is the splanchnopleuric layer. And after the formation, you have a part of the yolk sac pinched off, and the next formed yolk sac, you call it as secondary yolk sac or definitive yolk sac. And what do you mean by a chorion? Chorion is nothing but the trophoblast, both the cytotrophoblast and syncytial trophoblast, along with this somatopleuric extraembryonic mesoderm. So chorion definition, you might get question. What are the structures included in the chorion? So trophoblast, the both two layers, as well as the mesoderm lining. The mesoderm lining is the somatopleuric extraembryonic mesoderm. And you have the amnion, which is covering the amniotic cavity. Then you have the yolk sac. All these are extraembryonic structures. Now change is happening in the trophoblast. Trophoblast, we know there are mainly two layers, cytotrophoblast and syncytial trophoblast. There are many spaces developed in the syncytial trophoblast, which are actually filled with the maternal blood to form the maternal or to begin the maternal circulation. So this stage is formation of the spaces within the syncytial trophoblast. It is known as the lacuna stage, and this happens in the second week. Now the endometrial capillaries will be actually invading the lacuna spaces, and once these spaces are filled with maternal blood, that is the first point when the uteroplacental circulation is established. So when is the uteroplacental circulation established? That also happens in the second week of development. And you can see some of the cytotrophoblast cells pointing towards the syncytial trophoblast as a line. So this is actually the formation of primary villus. If you take a section at this point, you can see that in the middle, you can see the cytotrophoblast and surrounded by the syncytial trophoblast. So this is the beginning of chorionic villi formation, the primary chorionic villus. Now changes in the endometrium. We know, we have already mentioned the residual reaction means once the endometrium is implanted, after that, we call the three layers as decidual layers. And how this is happening is, the cells will be swollen up with the glycogen and lipid. And that is what you call as decidual cells. So let's see what are the changes. The blastocyst after implantation lies completely in the stratum compactum. And the endometrium surrounding the conceptus and the lining the cavities get differentiated. So you can see that this is the blastocyst, which is getting implanted in the stratum compactum layer. And this is stratum spongiosum and stratum basale layer. So in the stratum compactum, it is completely implanted, and the point of entry is actually closed by fibrin plug. Now you can see what are the differentiation happening for the endometrial layers. This is the point of attachment. This is known as the endometrium lying at the embryonic pole is called as the decidua basalis. And the rest of the fetus is actually covered by the remaining part, and that is known as decidua capsularis or the embryonic pole. And the remaining uterine cavity, the stratum compactum of the remaining uterine cavity is what you call as decidua parietalis. So this again can be asked as an image-based question. So the decidua at the embryonic pole, you call it as basalis. The remaining part of the fetus is covered by capsularis, and the remaining part of the uterine cavity, you call it as decidua parietalis. Now, something about hydatidiform mole or molar pregnancy. So it is actually a gestational trophoblastic disease where non-viable fertilized egg, the fertilized egg is not viable, but it still gets implanted in the uterus. And it is said that it mainly contains trophoblast tissue. That is again an MCQ, which is the tissue present in the hydatidiform mole or vesicular mole. It is the trophoblast. You won't get any part of the embryo usually because the egg is not viable. But the trophoblast will undergo proliferation, and the reason is paternal genes actually regulate the development of trophoblast. That is the reason why in most of the hydatidiform moles, the chromosomes will be transferred from the sperm. So this is enough for the development of trophoblast. And there are mainly two types. One is partial mole and the other one is complete mole. So in partial mole, you have the egg with haploid number of chromosomes, which is fertilized by two sperms or one sperm, which will later undergo mitotic division to form two. So the chromosome number can be either 69 or 92, triploid or tetraploid. So there is a contribution from the oocyte here. That is important. Complete mole means pregnancy without an embryo. So here it can happen with a single sperm when you call it as monospermic, or two sperms, but the oocyte is actually having no DNA, no chromosome. That is important. So complete mole means there should not be any chromosomal contribution from the oocyte. So here the genotype will be, if it is one sperm, it will undergo mitosis to form two, and the diploid number will be maintained. And if there are two sperms also, the diploid number will be maintained because there are no chromosomal contribution from the oocyte. And it is the complete hydatidiform mole which develops into choriocarcinoma or invasive mole. So that is also asked as an MCQ. Which one is more prone for formation of choriocarcinoma or invasive mole? Now something about genomic imprinting. Genomic imprinting means if you happen to get a genetic material, suppose a part of a gene from one of the parents. It can be either from mother or father. But if you are getting the same chromosome, still the results are different. If you get the same chromosome from the father, the effects are different. If the same chromosome from the mother, the effects are different. So if you get a microdeleted chromosome 15 from the father, you call it as Prader-Willi syndrome. And if you get again a microdeleted chromosome 15 from the mother, then it results in Angelman syndrome. That is, and these are the examples of genomic imprinting, differential expression of the homologous chromosome. This is also asked. So Angelman syndrome, you can remember this code, SAPI. These are the four important components: seizures, aphasia, paroxysms of laughter, and intellectual disability. These are the four components of Angelman syndrome. So Angelman syndrome happens when that chromosome is derived from the mother. Angel mother, you can think like that. Prader-Willi, the code is HHOS, which includes hypotonia, hypogonadism, obesity, and severe intellectual disability. So severe intellectual disability in the form of temper, outburst, then compulsive behavior and all. Then you can see weak muscle tone, hypotonia, and some other features like railroad track ears and are present. But you can remember these four important components, and Prader-Willi happens when that chromosome is derived from the father. Now, X inactivation is nothing but you have two X chromosomes in female, right? But only one X chromosome in male. So if there are two, actually it should be an overdose in females, but that should not happen. So what will happen is one of the X chromosomes will be inactivated, and that will be seen as bar body. But these X chromosomes are actually very active in the early female embryos, but late towards towards development, towards the later stages, what happens is one of the X chromosomes will be inactivated, and that is what we call it as bar body. All the following structures are formed during second week: epiblast, intraembryonic mesoderm, yolk sac, primary villus. So it is the intraembryonic mesoderm which is not formed. So third week, 3 layers. You remember like that. And the third layer formed is intraembryonic mesoderm. So second week, you won't get intraembryonic mesoderm. Intraembryonic mesoderm will be formed only in the third week, because it is in the third week you get the 3 layers. Lacuna stage is in which stage? We mentioned about the lacuna stage where the lacunae are filled with maternal blood. That happens in the second week. Decidua covering the embryonic pole, the point of attachment, that is decidua basalis. Hydatidiform mole can have all the following genotypes. We can see that there are chromosome numbers with XX, XY, XXY. All these are possible, but XO is not possible because you always have multiples of sets of chromosomes. There is no missing 6 chromosomes. Okay, so that is very important. So there is no XO, XX, XY, XXY, all these combinations you can get. An example of differentiated expression of homologous chromosome regions depending on the parent from which the genetic material is derived. Both are example. Angelman if it comes from the mother, Prader-Willi if it comes from the father. Microdeletion of chromosome 15. Which is true about X inactivation. One of the two X active X chromosomes in female is inactivated because else it will be an overdose because our males they are poor, they are having only one X, but females they are having two X. So if both of them get expressed, it will be an overdose. So one will be inactivated. The inactivated X chromosome we call it as bar body. X chromosomes in the cell of early female embryo remain active. Yes, it is not, it is inactive towards the later stages. So all the statements are true regarding X inactivation. Now we are moving on to the third week. It is gastrulation. Gastrulation, the term means formation of the third germ layer. We just mentioned about the ectoderm and endoderm, primitive ectoderm and endoderm. It's primitive because the proper ectoderm and endoderm are formed only after the formation of the intraembryonic mesoderm. Okay, so that point you have to remember. In the second week, you have only primitive ectoderm and endoderm. In the third week, you get all the three main layers, ectoderm, endoderm, and intraembryonic mesoderm. And this is the point of maximum teratogenic insult because you have many important structures formed at this point. The primitive streak, which is called the primary organizer. So teratogenic insult maximum happens at this point of time. So what are the changes happening? Trilaminar germ disc is formed by the invagination of cells from the epiblast. Epiblast, it is provided with many cells which are pluripotent. Pluripotent means which can give rise to all the three germ layers. And these layers will be moving inside and will be lying between the primitive ectoderm and endoderm. And finally, you have the three germ layers. It is the point when you have the axial orientation of the embryo established. And this is the point where the morphogenesis, the differentiation begins. Now, what are the changes happening for the epiblast? You can see that some of the cells are arranged in the middle and they form the neuroectodermal cells, and the caudal end you have the primitive streak, and the remaining cells are called or modified as surface ectoderm. These are the changes happening in the epiblast layer. Surface ectoderm, neuroectoderm, primitive streak. These are all terms seen in connection with the epiblast. Now something about primitive streak, very, very important. When is it formed? It is the 15th day when you get the formation of primitive streak. And once the primitive streak is formed, you can say that, okay, this is the head end of the embryo. This is the tail end of the embryo. So only after the formation of primitive streak, you can say the craniocaudal axis of the embryo. Now, primitive streak is otherwise known as the primary organizer. Why? Because all the remaining steps are controlled by this primitive streak. And this induces the formation of two important structures. One is the intraembryonic mesoderm, and you have the formation of notochord. These are the two important structures formed from the primitive streak. The primitive streak, if you see, you can see that there is a head end and there is a tail end. So the head end is known as primitive node or Henson's node. So Henson's node belong to which of the embryonic structures? So one of the options can be primitive streak, primitive node. Okay, then there is a pit formed in the primitive node that is known as primitive pit, because you need a pit on the primitive node so that the cells can migrate through the pit into the space between the epiblast and hypoblast. After that, you can see the cells are migrating and forming the third layer, that is the intraembryonic mesoderm. And later the cells, the epiblast and hypoblast cells, are replaced by these differentiating cells, and then you call these layers are as definitive ectoderm and definitive endoderm. So finally, you get all the three layers, ectoderm, mesoderm, and endoderm, formed from the pluripotent epiblast layer. Functions of the primitive streak. It gives rise to intraembryonic mesoderm, notochord, and septum transversum. It established the craniocaudal axis of the embryo. That is one short, one MCQ which can be asked. and it also established the right and left halves of the embryo. So when is the right and left halves of the embryo established? After the formation of primitive streak. All are true about the tumor. What is a tumor? Can someone type in the chat box? What is this tumor? Can you identify it? Most common tumor which happens in the newborn. Very good. Anju, yes, sacrococcygeal teratoma. So it is sacrococcygeal teratoma. So all are true about this tumor. It contains tissue derived from all the three germ layers, because once we know it as teratoma, it will be containing all the three germ layers. It is more common in female newborns. It is benign and have good prognosis. It is a remnant of notochord. What can be the answer? A, B, C, or D? What can be the answer? Can I have a right answer? Yes, Jibin. So it is not the remnant of notochord. It is actually the remnant of primitive streak. It is benign and it have good prognosis, but it is not the remnant of notochord. That is very important. Okay. So it is actually the remnant of primitive streak, sacrococcygeal teratoma. So what happens to the primitive streak? After the 4th week, it actually diminishes in size because there is no longer a need for primitive streak. And the remnant is seen as sacrococcygeal teratoma in the sacral region. It is more common in female newborns and it is benign. And that is the reason why we say the maximum teratogenic insult happens between 15th and 18th day. Now, what are the steps involved in the formation of notochord? First, you can see that from the cephalic end of the primitive streak, you have one process that is known as notochordal or head process. You just know the different steps because it is always asked what is the continuity of the continuity in the formation of the notochord. You should be knowing this. So this is first you have the notochordal process or head process. Then you have a canal formed that is known as notochordal canal. Then you have a neuroenteric canal which communicates between the amniotic cavity and yolk sac. The reason for the formation of neuroenteric canal is this is the epiblast. You have the neuroectodermal layer here, which means the development of brain happens here, isn't it? Neural tube formation happens here. So in order to provide nutrition, we have the neuroenteric canal through which the nutrition can be taken to the amniotic cavity so that it nourishes the neuroectodermal layer. Then you have the notochordal plate formed and then it escalates and finally you have the definitive notochord. So these are the steps which are included in the formation of notochord. Notochordal process, canal, neuroenteric canal, notochordal plate and definitive notochord. Then functions of notochord, it forms the central axis of the embryonic disc and it is actually acting as a mold on which the vertebral column is formed. And it induces the formation of neural tube. So, and vertebral bodies are formed, and once vertebral bodies are formed, the remaining part which is lying between will be forming the intervertebral disc. It is replaced by the vertebral column. The notochord is replaced by the vertebral column and some of it will be remaining as nucleus pulposus. This is the intervertebral disc. You can see there are two parts. The outer you call it as annulus fibrosus and the inner part you call it as nucleus pulposus. This is actually the remnant of the notochord and it also forms the apical ligament of dens. So these are the two remnants of notochord. Now you have to talk about the allantois. So it is just an endodermal diverticulum which begins on 16th day. And what is the role of this diverticulum? It is actually pointing into the umbilical cord and the role of the allantois is actually to vascularize this umbilical cord. That means vascularize means the umbilical blood vessels are formed from the vascularization of this allantois. And during the fetal period itself, once the umbilical cord is vascularized, the remnant will be seen as urachus. And after birth, the remnant of the same urachus will be seen as median umbilical ligament. You have to think about this term. Median, it is not medial. There is only one urachus, right? So there is only one in the middle, that is median umbilical ligament. So this is a structure which has got two remnants. That means one during the fetal period and the other one after birth. So allantois results in a remnant during the fetal period, that is urachus, and urachus after birth becomes the median umbilical ligament. That's very important. Now, coming to the embryonic disc, you have the precaudal plate, you have the cloacal membrane, then you have the notochord, and you have the pericardial bar. These are some of the important terminologies you should be knowing. The precaudal plate actually is a site of future oropharyngeal membrane. Cloacal membrane is actually getting differentiated as anal and urogenital membrane. Then you have the notochord, and then you have the pericardial bar. So these are some of the terminologies you should be knowing, and you should know the position of these structures. Now, some of the changes happening to the trophoblast. Trophoblast goes through three stages: primary villus, the villi formation, the primary villus, secondary villus, and tertiary villus. This is again a favorite part. So, primary villus has got nothing but the cytotrophoblast in the middle and syncytial trophoblast outside. When you get the mesodermal core in the middle, you call it as secondary. When you get the fetal capillaries in the middle, you call it as tertiary. Okay, so these are the changes which happen during the formation of villi. So, which is the mesoderm which you get here? This is outside the embryo. So, the mesoderm here is extra embryonic mesoderm. It is not intraembryonic mesoderm. That is one of the commonest mistake which you make. This is the extra embryonic mesoderm which you get, and you have the fetal capillaries. Now, the secondary villi with blood vessels, you call it as tertiary villi. Now, each tertiary villus presents the structures from center to periphery. So, what are the structures which you get from center to periphery? Suppose you are standing inside the fetal capillary and you are looking at the maternal blood. What are the structures? First, you will be seeing the endothelial cells of the fetal capillaries. Then you can see the mesoderm, the extraembryonic mesoderm. Then you can see the cytotrophoblast. Then you can see the syncytial trophoblast. And between the villi, the intervillar space will be filled with the maternal blood. So these are the different layers. This is again a favorite question. Identify the clinical condition. Can someone type it in the chat box? Phocomelia, amelia, cyanomelia. Can I have the answer? I will give you a clue. It is just like a mermaid. Another name is mermaid. What can it be? It is cyanomelia. Okay. So cyanomelia or caudal dysgenesis syndrome. It's otherwise known as mermaid syndrome. And what happens is during gastrulation, we mentioned that an additional third layer, intraembryonic mesoderm, is formed. Sometimes this mesoderm is not properly formed in the caudal region of the embryo. Then what will happen? The caudal part, like the lower limbs, the urogenital system, the vertebra, and all won't be formed at the distal. That is the reason why we have the limbs fused. So caudal dysplasia is actually a manifestation of gestational diabetes with elevated insulin levels. You can get it as one of the options. Then something about transposition of viscera in thorax and abdomen, that is known as situs inversus. It is commonly seen in the syndrome known as Cartagner syndrome or immotile cilia syndrome. There is complete situs inversus in Cartagner syndrome with bronchiectasis and chronic sinusitis. We can see that the structures which were on the right are actually transferred to the left. This is known as complete situs inversus or Cartagner syndrome. Now, there is something else known as laterality sequence. Laterality sequence means whether a person is predominantly left-sided or right-sided. That means some of the structures of the left will be seen on the right as well. So, which is the deciding factor? So, the options will be having polysplenia or hypoasplenia. These are the two options which you will be getting. So, if you get a left-sided laterality, that means the spleen will be seen on the right side also. isn't it? So you will be having two spleen or more than two. That condition is known as polysplenia. So polysplenia will be seen in left-sided laterality. And if a person is having right-sided laterality, right-sided means the structures on the right will be seen on the left. So there is no spleen on the right side normally, isn't it? So if it is repeated on the left, you won't be getting any spleen. That is known as asplenia or sometimes hypoplastic spleen. And the signal which is controlling it is serotonin or 5-HT, and that is a signal molecule. So if the mothers are using SSRI, selective serotonin reuptake inhibitors, as antidepressant, they are at high risk of having this laterality sequence. The formation of intraembryonic germ disk is called gastrulation. Which is the correct sequence? Can someone answer this? Anyway, it starts with head process. So there are two options with head process. It is head process, neuroenteric canal, notochordal plate. Then you have the definitive notochord. So what is true about notochord? It forms central axis, it induces neural tube formation, it forms intervertebral disc. All are correct, isn't it? Apical ligament of Tenz is the remnant of apical ligament. Can someone say? Apical ligament? Yes, notochord. Urachus is a remnant of allantoic diverticulum in the fetus. Okay. In adult, the same urachus is seen as median umbilical ligament. Central core of mesoderm surrounded by cytotrophoblast and syncytial trophoblast. If you see mesoderm in the middle, it is the secondary villus. If you see blood vessels in the middle, it is tertiary villus. Left-sided laterality has. Can someone answer? Left-sided. Polysplenia. Very good. Now coming to neurulation. So we have 3 germ layers formed by the end of 3rd week. Then you have in the 4th week, some of the important events are formation of somites, folding of the embryo, then face and limb buds by the end of 2nd month. So the intraembryonic mesoderm, they are actually differentiated into paraxial, intermediate and lateral plate mesoderm. Paraxial around the axis, then intermediate, then lateral plate. We'll just rush through some of the important terminologies. You should be knowing about the somites. So there are pre-otic somites which are lying in front of the otic capsule, and they are actually resulting in the formation of the extrinsic muscles of the eye. Then you have the caudal to the otic vesicle. They are the somites and somatomeres. Somatomeres are otherwise known as post-otic. You can see there are mainly 7 somatomeres, and the remaining are called the somite proper. So this again you should be knowing. Pre-somite period 15th to 20th day. Somite period 20 to 30th day. And post-somite after 30th day. 15 to 20, 20 to 30, after 30. These are the 3 different periods. And 4th week is known as the somite period. And how many somites you expect? You expect roughly 44 pairs at the end of 1st month. And the somites, they are actually differentiated into 2. Dorsolateral and ventromedial. So this part, dorsolateral, it is actually forming the dermomyotome, and this part, the ventromedial, is actually forming the sclerotome. So the derivatives you can say, the dermal plate results in the formation of dermis. It is not the epidermis, it is the dermis of the skin and subcutaneous tissue. Medial part or the myotome part forms the skeletal muscle, tongue and diaphragm. The ventromedial part, the sclerotome, is actually forming the vertebral column and the ribs. These contributions you should be knowing, the somites and their derivatives. Dermal plate, muscle plate and the sclerotome and their derivatives. And it is segmented in the upper part but unsegmented in the lower part to form the nephrogenic cord, which actually results in the formation of kidney and sex glands. So intermediate, paraxial, intermediate and lateral plate. Paraxial, somite. Intermediate gives rise to only these 2 structures, kidney and the sex glands. That is also very important. And you have the lateral plate mesoderm. Lateral plate mesoderm actually gives rise to these cavities, lining of the cavities, pericardial, pleural, and peritoneal cavities. If it is tough for you, you just remember the main three mesoderms: paraxial, intermediate, lateral plate. Intermediate gives rise to kidney and gonads. You just remember that. And paraxial gives rise to somites. Lateral plate forms the cavities, the layers of the cavities. So parietal part, somatopleuric layer forms the parietal layer of the peritoneal, pleural, and pericardial cavities. The parietal layer. And the splanchno-pleuric layer forms the visceral layer of the cavities. You just remember that. Now coming to the derivatives, you can see all the muscles of the body except iris and erector pylori, they are actually derived from the mesoderm. Now coming to the ectoderm, surface ectoderm gives rise to epidermis, hair, nails, stomodium, which forms the primary oral cavity, and it is by fourth week you have the communication established by the rupture of the buccopharyngeal membrane. So that is something very important. By fourth week, the communication is established between the gut and the oral cavity. So ectoderm, the proctodium, stomodium and proctodium, the two regions, isn't it? So the proctodium is seen at the distal end and the floor is actually forming the cloacal membrane. The cloacal membrane is actually forming the anal and urogenital membrane, which actually ruptures and communicates with the exterior in the form of anus. Now coming to the neurulation, just a quick review through the steps. The notochord is actually responsible for formation of the neural tube. You can see the neural groove which with the neural folds and the fusion occurs and complete neural tube is formed, and some of the cells which lie on either side and which is not fused into the neural tube, you call it as neural crest cells. And you can see two neuropores, the anterior neuropore and posterior neuropore. Anterior neuropore, this is again a favorite question, closed at 20 somite period and posterior neuropore closed at 25 somite period. So 20 somite period is middle of fourth week and 25 somite period means the end of fourth week. The cranial end will give rise to brain and the caudal end give rise to the spinal cord. And you have the neural crest cells. So the neural crest cells gives rise to the Schwann cells, the cells of adrenal medulla, neurons of the autonomic ganglia, cells of dorsal root ganglia. So the important things you remember: cells of the adrenal medulla, C cells of the thyroid gland, odontoblast. So these are the some of the favorite things which you can get. Then these are some of the derivatives which you should be knowing. Then something about the primitive gut, the extra embryonic, the umbilical vesicle or the definitive yolk sac. You can see the definitive yolk sac which is getting incorporated into the gut. You have the foregut, you have the midgut, and you have the hindgut. So the midgut portion is actually communicating with the yolk sac through a communication that is known as the vitelo-intestinal duct. Now the epithelial lining of GIT, tongue to ampulla of Vater in the duodenum, that is actually forming the epithelial lining of GIT. Now it is also forming the epithelial lining of the respiratory system and some of the glands, tonsil, thymus, and thyroid. Now coming to which is true about the given clinical condition. Can someone say what is the clinical condition? Failure of closure of anterior neuropore, brain fails to develop, diagnosed prenatally. Yes. So the answer is all the above. It is failure of closure of anterior neuropore, brain fails to develop, diagnosed prenatally, and just 400 microgram of folic acid can prevent it. So neural tube defects, the main thing is anencephaly. It is failure of closure of neural tube in the cranial region. Brain fails to develop and it is diagnosed prenatally and terminated. 400 microgram of folic acid, that is the preventing factor. Identify the neural tube defect. Can someone identify the neural tube defect? Anencephaly, spina bifida, sacrococcygeal teratoma, none of the above. Yes, very good. It is spina bifida. So spina bifida means failure of closure of neural tube anywhere from cervical region to caudal region. Anywhere from cervical to caudal region, if there is failure of closure, you call it as spina bifida. And lumbosacral region is the most common site. There are mainly three types of spina bifida. One is spina bifida occulta. Occulta means vertebra is not completely closed, but spinal cord won't protrude out. And so if you look at the skin region, there will be skin with a tuft of hair. So it is spina bifida occulta. And it is not associated with increased AFP. That is very important. Spina bifida occulta, no increased AFP. Now the other two ones are meningocele and myelomeningocele. So what happens in meningocele means through the defect in the vertebra, the meninges herniates between and the nervous system is remaining intact. It is not coming out, and this is least common. And what do you mean by myelomeningocele? The spinal cord elements, the nervous elements also comes out. This is said to be more severe. So this is known as myelomeningocele. And myeloschisis is the most severe form of myelomeningocele, where this is actually seen exposed to the outer aspect. There is not even an overlying membrane. That is known as myeloschisis. So these are the different terms which you should be knowing when we discuss about the spina bifida. So just I had skipped some of the slides. Why? Because I was waiting for the slide. This will give you an overview of the derivatives: ectoderm, the surface ectoderm derivatives, and neuroectoderm derivatives. Neuroectoderm, some of the favorite answers in the options which you get for NEET are pineal gland, the derivative of neuroectoderm; oligodendrocytes, neuroectoderm; then lens of eye, surface ectoderm. These points, if you remember, it's not possible to remember the entire thing, but still you can focus on these because these are usually the answers in the MCQ. Then neural crest cell, adrenal medulla is from the neural crest cell, that you should be remembering. Then you have the pigment cells, then you have the meninges, pia and arachnoid, then odontoblast, endocardial cushions, all these are from the neural crest cells. Then mesoderm. Mesoderm, when we hear about mesoderm, it is mainly the muscle cells. Then you have the connective tissue, then bone and cartilage, gonads and internal reproductive organs, kidney and ureter. Kidney and gonads, we can say that as derived from the intermediate intraembryonic mesoderm. Then you have the notochord, nucleus pulposus, the remnant. So all these things are derivatives of mesoderm. Derivatives of ectoderm, endoderm, mesoderm, you will definitely get one question normally if you get a question from embryology. Then endoderm, it is usually the lining of the GIT, respiratory and genitourinary system. Then also pancreas and sublingual salivary glands. These are usually seen as the answers in some of the MCQs. Yolk sac derivatives, you have the primordial germ cells. When we discussed about the spermatogenesis and oogenesis, we mentioned about the primordial germ cells, isn't it? So they are actually located in the yolk sac, and also the early blood cells and blood vessels. All are derivatives of paraxial mesoderm. Can someone answer? Except rheotic somites, somatomeres, gonads, postotic. What can be the answer? Paraxial. The answer is gonads. Why? Because gonads and kidney. You just remember these two things. They are from the intermediate intraembryonic mesoderm. Somite period is from 20 to 30 days. Kidney develops from, I've said it many times, kidney develops from, very good, intermediate mesoderm. Suprarenal cortex is derived from. Cortex is from the mesoderm. Medulla is from the neural crest cells. Primary inducer of neurulation. After the formation of which structure, you will get neural tube formation. Primary inducer. It's not whether neurulation means neural tube formation. Which structure results in the formation of neural tube? It is the notochord. Only after the formation of first primitive streak will form. Primitive streak will form intraembryonic mesoderm and notochord. Notochord will induce the formation of neural tube. That is the sequence. Okay. First, the primary organizer, primitive streak. It will induce intraembryonic mesoderm and notochord. Notochord will induce the formation of neural tube. So here the answer is primary inducer of neurulation. It is the notochord. That is the sequence. First primitive streak. Primitive streak induces intraembryonic mesoderm and notochord. Notochord induces neurulation. When we talk about development of fetus, one structure formed will induce the formation of other structure, and it is just like a sequence. That is why we call it as inducers. Only if notochord is formed, neural tube is formed. Only if primitive streak is formed, notochord is formed. Okay, hope you got the connection. So here the primary inducer of neurulation is notochord. All are derivatives of neural crest cells except erector pili. Very good. Now some of the screening tests. Fetal period, we mentioned it as 9th week to birth. So estimation of fetal age is done by two important measurements: crown rump length. That is usually in the first trimester, say 14 to 16 week. Up to 14 to 16th week, you will take the crown rump length, and after that, it is usually the crown heel length. And crown rump length is usually mentioned in millimeters, and crown heel length is usually mentioned in centimeters. Other measurements which will help you to say the ages: biparietal diameter, head circumference, abdominal circumference, femur length, foot length, weight, etc. Now, maternal serum screening. This is very, very important in under gynec as well as pediatrics. You will get these questions. Serum alpha fetoprotein, AFP. It is actually produced by the fetal liver by say around 14th week, and it reaches the maternal circulation through placenta. So, serum alpha fetoprotein is decreased in which condition? Decreased. It is not increased. The question is decreased. Neural tube defect, omphalocele, Down syndrome, intestinal atresia. Can you say? Very good. It is in Down syndrome where you get decreased. It is increased in all except sacrococcygeal teratoma, omphalocele, gastroschisis, trisomy 18. What can be the answer? Again, the question is, it is decreased in which condition? Can someone say? Yes, if you can correlate with the previous question, most of the trisomies end up with decreased level of alpha fetoprotein. Okay. So serum alpha fetoprotein, increased and decreased conditions. This you should remember, very important. Decreased in most of the trisomies: Down syndrome, trisomy 18, triploidy, and sex chromosomal anomalies. In all the rest of the conditions, mostly you will get an increased neural serum alpha fetoprotein level. Neural tube defect, sacrococcygeal teratoma, abdominal wall defects, intestinal atresia, everything you will get an increased level of serum alpha fetoprotein. And some of the important tests: triple test, quadruple test. Okay, so triple test means Kettering or Bart's test. It is usually done in 15 to 18 period. It is done to detect the chromosomal abnormalities and neural tube defect. The main levels which you focus on during the triple test are AFP, unconjugated estriol, and beta HCG. So in trisomy 18, you get everything low. But in Down syndrome, only one thing is elevated, that is beta HCG. The other two again remain low. Okay, so that is very important. If you get a Down syndrome, if you do a triple test, beta HCG will be elevated. So in triple test, Down syndrome gives the following result. Very easy, right? You will get increased HCG, but the other two, AFP and unconjugated estriol, will be decreased. Quadruple test or quad test, if you add inhibin A along with triple test, you call it as quadruple test or quad test. So what about the inhibin A level? In Down syndrome, again it will be elevated, but Edward syndrome, again it will be low. So the Edward is mostly everything low. So quadruple test for Edward show inhibin. Answer? Yes, decreased. So Edward is everything low. Chorionic villus sampling is the process by which you insert a needle into the placenta and you take a sample and you will do the genetic analysis. Roughly 5 to 30 mg of tissue is aspirated, and the time period is usually done during 10 to 11 weeks. Amniocentesis means how much will you take? 20 to 30 ml. And before 14 weeks, you should not be doing amniocentesis. Why? Because you can injure the embryonic disc and all. Now, fluid is analyzed over. What are the structure? What are the levels which you will assess in an amniotic fluid? AFP, acetylcholinesterase. Then you can look for the fetal cells which are sloughed off into the amniotic fluid. You can take, you can do karyotype if you're suspecting some anomalies. You can take those cells and you can culture and karyotype. Then PCR and genotyping also to detect the genetic anomalies. Fetal blood sampling, it is done during the 24 to 34 weeks, again for chromosomal analysis. Then pre-implantation genetic diagnosis, it is otherwise known as PGD. You should be knowing the expansion, PGD, pre-implantation genetic diagnosis. In this, what happens is when we do in vitro fertilization, sometimes we will be expecting some major anomaly for the fertilized oocyte. So before implanting, you will test the you will test for genetic abnormality, because otherwise what will happen? You will be implanting an embryo which is having some genetic anomaly. So in order to prevent that, before implanting, you will do genetic analysis. That is known as pre-implantation genetic diagnosis. And that is mainly done in vitro fertilization. Cardiotocography, you know it. Then arterial supply of the gut. This is again very important. Foregut, midgut and hindgut. Foregut, you have the celiac artery. Midgut, superior mesenteric artery. And hindgut, you have the inferior mesenteric artery. The midgut, the rotation is 270 degrees. Sometimes all these degrees can be asked. Then you should know the pre-arterial segment and post-arterial segment. Pre-arterial segment forms the coils of jejunum and ileum. Post-arterial segment includes the lower ileum, cecum, appendix, ascending colon, and the part of the transverse colon. So this pre-arterial segment and post-arterial segment you should be knowing. And this will be actually forming a loop and will be herniating through from the abdominal cavity by 10 pic. This is known as physiological herniation, and this will normally go back. And some of the structures which become retroperitoneal, that means it will be suspended by peritoneum, and after rotation, it will lose its peritoneum and it will be placed towards the posterior aspect. You should be knowing this. Duodenum, ascending colon, descending colon, and rectum. These will be devoid of peritoneal folds. And which all places you will get the original mesentery. You will get the original mesentery for the small intestine, mesentery of jejunum and ileum. Then for the transverse colon, you call it transverse mesocolon. And for the sigmoid colon, you call it as sigmoid mesocolon. So these are part of the mesentery. So in the beginning, you call everything as mesentery. That is why we say it as original mesentery. And this will be modified according to a region. That means mesentery of jejunum and ileum in the small intestine, transverse mesocolon in the transverse colon, sigmoid mesocolon and sigmoid colon. These are the remnants of the original mesentery. And you can see that the dorsal mesentery around the stomach forms the great omentum. Duodenum forms the mesoduodenum. Colon forms the dorsal mesocolon, and jejunum and ileum is actually forming the mesentery proper. So all these are derived from the dorsal mesentery. That means from the posterior aspect. So the derivatives of dorsal mesentery, that will be the question. So mesogastrium, mesoduodenum, mesocolon, and the mesentery proper. Ventral mesentery, which is lying in the front. So most of the ventral mesentery will degenerate. We can see that none is actually remaining. Only in this region you have the ventral mesentery. So this is actually seen from the terminal part of esophagus, stomach, and upper part of duodenum. And what happens to this ventral mesentery? When the liver is formed in the middle, it divides the entire ventral mesentery into two parts. One is the part which is lying between the liver and stomach, you call it as lesser omentum, and the part which is lying between the abdominal wall and liver, you call it as falciform ligament. So derivatives of ventral mesentery, lesser omentum and falciform ligament. Now coming to the anterior body wall defects. This is again a favorite question. One is if you get a defect in the thorax, you call it as ectopia cordis. When you get a defect in the abdomen, you call it as gastroschisis. And sometimes the physiological herniation, after a physiological herniation, the gut tube will fail to go back into the abdominal cavity. That is omphaloceal. So gastroschisis and omphaloceal, you might be mistaken. The difference is omphaloceal is covered by a membrane, whereas gastroschisis, the entire contents just lie outside. So omphaloceal, you can see an amnion covering it. And this is a condition where you get chromosomal abnormalities. For gastroschisis, you won't get chromosomal abnormalities. So in MCQ, you can get that, which is associated with chromosomal abnormalities. So omphalosil is associated with chromosomal abnormalities and elevated AFP. So identify the clinical condition. Can you identify? Omphalosil, ectopia cordis, divarication of recta, ectopia vesicae. Very good. Ectopia cordis. What is this condition? You can see the contents lying outside. It is gastroschisis. What is this condition? Discovered by a membrane, amnion. Omphalosil. Very good. What is this condition? Cloacal extrophy, divarication of recti, ectopia cordis, bladder extrophy. Yes, very good. It is bladder extrophy. Then something about congenital diaphragmatic hernia. This term you should be remembering. Failure of fusion of the pleuroperitoneal membrane. There will be a defect, and that defect is known as through that defect, the contents will herniate into the thoracic cavity. That is known as diaphragmatic hernia. The most common on the left side. This is also very important. So when the organs push into the thoracic cavity, the lung will undergo hypoplasia. The commonest one being Bogdalek, which is seen on the posterior aspect, and the anterior aspect you call it as Morgaginian hernia. Sometimes there will be thinning of the diaphragm, that is known as ventration of diaphragm, and sometimes there will be defect in the central tendon region. So you can see the defects here, and you can, through this defect, you can see the contents protruding into the thoracic cavity, and as a result, the lung will be hypoplastic. Fetal period is, just a quick recap. When will you call it as fetus? A, B, C, D. Very good. 4 weeks. Is it 4 weeks? Up to 8 weeks, you call it as embryo. After 8 weeks, that means from 3rd month onwards. Okay, from 3rd month onwards to birth, you call it as fetus. First 8 weeks, you call it as embryo. And in that, the first 3 weeks, you have the 3 germ layers formed. 3 means 3 germ layers. So that is germinal period. And 4 to 8 weeks, you call it as embryonic period proper. After 8 weeks, that means 9 week onwards, up to birth, you call it as fetus. I have just given another term, just to confuse you. Derivatives of foregut include all except duodenum up to second part, liver and extrabiliary, respiratory, except, which is not derived from foregut. A, B, C, D. Everything, duodenum up to second part, liver, extrahepatic, respiratory, everything, they are derived from the foregut. Artery of midgut. Yes, superior mesenteric. Cilia trunk, superior mesenteric, inferior mesenteric. The 3 gut arteries. Post-arterial segment include all except cecum, appendix, distal duodenum, proximal 2/3 of transverse colon. Yes, distal duodenum. Chromosomal abnormalities present in gastroschisis, omphalosil, both none. I have already mentioned which condition is having chromosomal abnormality associated. Very good, omphalosil. Cantrell's pentology include both. You can have defects in the midline, either in the thorax or the abdomen. So you can get both omphalosil, gastroschisis, everything you can get. That is what is meant by Cantrell's pentology. All are true about congenital diaphragmatic hernia except failure of pleuropetal, most common on the right side, pulmonary hypoplasia common as Bogdalek. It is most common in left side. Something about placenta. Circulation of placenta, you have 80 to 100 spiral arteries which are providing blood. Intervillous space contains 140 ml and 500 ml of maternal blood circulates through intervillous space. Okay, and blood is exchanged. So since it is 140 ml capacity, it has to go 4 times so that the circulation is maintained. Then umbilical cord, you know the jelly is known as Wharton's jelly. It contains hyaluronic acid, fibroblast and macrophages. This very important. You have two umbilical arteries and one umbilical vein, isn't it? It is derived from the anterior division of the internal iliac artery. After birth, the part which is closer to the internal iliac artery will remain as superior vesical artery. Part distal to it, towards the umbilicus, will be seen as a remnant that is known as medial umbilical ligament. Okay, it is not median. What was the median umbilical ligament remnant of? Median, we have already discussed. Urachus, very good. So medial umbilical ligament, it is remnant of umbilical artery. Umbilical vein, you know only one vein, that is left. Left umbilical vein is left behind. You can remember like that. And it connects with the portal vein, and the remnant you can call it as ligamentum teres hepatis. Vital intestinal duct, you can see it is a connection between the midgut and yolk sac, and the remnant is known as Meckel's diverticulum. Allantoid diverticulum, we have already mentioned. The remnant in fetus, you call it as urachus, and in adult, you call it as median umbilical ligament. And it is actually attached to the apex of the urinary bladder, the remnant. Then placental membrane or the placental barrier, this we have already mentioned. When you look from the fetal capillary towards the exterior, what are the different layers? Endothelium of the fetal capillary, you have the extraembryonic mesoderm, you have the cytotrophoblast, you have the syncytial trophoblast. So in the beginning, you have 4 layers up to 3rd month. Before the placenta becomes mature, you have 4 layers. So the nutrition has to pass through all these 4 layers. So it is really hectic task. So what happens during when the placenta becomes mature, the fetal capillaries will move towards the periphery, and it will remove all the 2 layers, that is the mesoderm and the cytotrophoblast from its side, so that when you look from the fetal capillary, you will be seeing only the endothelium of fetal capillary and the syncytial trophoblast. So in mature placenta, the placental barrier contains only 2 layers. One is fetal capillary and the syncytial trophoblast. This is known as vasculo-syncytial membrane. And there are 2 zones, you just remember. Alpha zone is a site of exchange and beta zone is a site of hormone synthesis. And human placenta is hemochorial. Agents which cross placental barrier, this is also very important. You can remember the viruses. Then you can remember the cocaine, heroin, steroid hormones, thyroxine, diethylstilbestrol. Some of it you can remember. Then placental hormones, you know, HCG, placental. HCG is important for maintaining the corpus luteum. We have already mentioned it. It also induces testosterone. Then it produces placental estrogen, placental progesterone, placental lactogen. Then something about twinning. With this, we'll come to an end. So twinning, it happens 1 in 80 births. There are mainly 2 types, monozygotic and dizygotic. Monozygotic twins are otherwise known as identical twins or like twins. It is actually fertilized by one oocyte and one sperm, and they will divide. So it is from one zygote you have the twins. So they will be having everything same, genetic constitution, appearance, structure, blood group, but only different thing is fingerprint, because fingerprints are actually formed when the fetus is within the uterine cavity. How they keep their fingers against the uterine wall determines the pattern of fingerprinting. Then monozygotic, bichorionic, these are the 3 different types of twins. Monozygotic, bichorionic, monozygotic, biamniotic, monochorionic, monoamniotic. Here you can see that in one you get 2 chorionic cavity. The next 2 type, there is only 1 chorionic cavity but 2 amniotic cavity is still there. In the third variety, you have only 1 chorionic cavity and 1 amniotic cavity, and this is said to be dangerous. And this happens when when the division occurs at 2 cell stage, you get monozygotic. It is from the zygote but with 2 chorionic cavities and 2 amniotic cavities. So it just looks like dizygotic twin. The next one is monochorionic biamniotic. When will this happen? It happens when the division happens after the formation of inner cell mass. If the inner cell mass is dividing, it means the placenta is already formed with 1 single chorionic cavity, but the remaining part will form the amniotic cavity. So there will be 2 amniotic cavity, but outer to it, you have 1 single chorionic cavity. And the third variety happens after the formation of bilamina germ disc. It is usually rare, but still it can happen. In that case, already the amniotic cavity is formed, already the chorionic cavity is formed, and the division happens within. Conjoined twins happen even after the formation of primitive streak, so that you will be having two organizing centers. And what do you mean by parasitic twin? So it is late twinning. And parasitic twinning means one of the conjoined twin will be becoming rudimentary and the other will be actually maturing to become the newborn. Then fetus in fetu is a condition where the parasitic twin is enclosed within the body of the co-twin. That is fetus in fetu. So thoracopagus when the thoracic regions fuse, pygopagus when the sacral region fuse, and the other one is craniopagus. Based on the level of fusion, this is how you differentiate craniopagus, thoracopagus, cephalothoracopagus fusion of head and thorax, pygopagus, the sacral region. This is dicephalous and this is craniopagus. You should know the difference. Dicephalous means one single body with two head. Craniopagus means the heads are fused. Vanishing twin means in the first trimester itself, one of the twin will die and will be seen as a remnant or fetus papacious, and it will just vanish off. That is known as vanishing twin. Superfecundation means usually in the ovarian cycle one oocyte is released. Sometimes multiple ova will be released and it will be fertilized by sperm from two or more partners. This is usually happening in polyovulatory mammals. Two or more partners, that is very important. That is what is meant by superfecundation. Can you identify the clinical condition? Hydrops fetalis, fetus papacious, twin-twin transfusion syndrome. Very good. Twin-twin transfusion syndrome. One is becoming smaller because it is acting as a donor. Superfetation means already a fetus is formed within the uterus and after that one more fetus is formed. So what is happening? Usually ovulation will stop with a pregnancy, but sometimes the ovulation will continue and in the next cycle, if there is intercourse, those oocytes will also be fertilized. So within the uterus, you will be having embryos at different stages. So if one embryo attains 9 months, the other one will be 8 months or 7 months, depending upon the time of fertilization of the second. Then polar body sometimes will get fertilized, and that is how you get a polar body, half identical twin, because half their genes are common from the mother, isn't it? Polar body means it is actually a part of the oocyte. So the twins will be having their genes from the mother common, but the other half will be different because two different sperms will be fertilizing. So that is what is happening when a polar body is fertilized. So identical twins, you have 100% of genes shared. Fraternal twins, you have 50%. Half identical twins share 75% of genes. This is usually asked. What is the drug? This condition is known as phocomelia. The limbs are very short. Yes, thalidomide. Core of primary mesoderm covered by cytotrophoblast and syncytial trophoblast. What type of villi? In the middle, you have mesoderm. Secondary villus. In the middle, you have capillaries, then it is tertiary villus. Trophoblast with extraembryonic mesoderm. What is it? Somatopluric extraembryonic mesoderm and the trophoblast. Amnion, chorion, allantois, yolk sac. Very good. That is chorion. Amount of maternal blood circulating through the intervillus space. Very good, 500 ml. All are true about umbilical arteries, except ventral division of internal iliac, proximal part superior vesical artery, distal part medial umbilical ligament, ligamentum teres hepatis is the remnant. Very good. So it is not umbilical artery, the remnant which you called as ligamentum teres. Can you say which structure gives rise to ligamentum teres hepatis? Vein. Very good. Remnant of allantois. Median, medial, lateral, mechal. A. It is only one allantois, so median. Fetus starts swallowing amniotic fluid by 5 months. Polyhydramnios occur due to polyhydramnios, all of the above. In maternal diabetes, anencephaly, esophageal atresia, you will get monochorionic biamniotic twins. Already the placenta is formed. So when would have the division occurred? Two cell stage, splitting of inner cell mass, splitting of bilaminar germ disk. When should have the division occurred? Very good, splitting of inner cell mass. So with this, I'm just winding up. I know we have lot to cover in anatomy, but general embryology, this is all I could do because it is a very vast topic. But many questions can be asked from this. So hope you had a quick review.